So this year at ASCO, Alicia Sequist and several others presented quite a bit of data on this new focus of liquid biopsies, actually our ability to recognize circulating tumor-free DNA. The specific molecular drivers that exist on tissue biopsies can now be isolated in the blood, and this is a major breakthrough. I suspect in the next 2, 3, 4 years that liquid biopsies, to a great extent, not completely, but to a great extent, will replace tissue biopsies. Specificity is quite high, on the order of 95%. The sensitivity is not quite as good, anywhere from 60 to 70 to 80%. In the context of T790, which Alicia Sequist discussed during a lung plenary session at ASCO, the concordance was actually quite good. It was about 83, 85% or so. Liquid biopsies, let's face it, are a lot easier than tissue biopsies. Non-invasive, much faster, much more convenient both to the patient and to the clinician. The expense would probably be considerably less, and it enables us to get information on patients who have tumors that are inaccessible to traditional biopsies, and also those with bone-only disease where the process of decalcification will often denature the DNA and make it impossible to really interrogate the tissue for molecular drivers, for specific oncogenic drivers. So we've come to recognize the existence of heterogeneity within tissue biopsies. We may biopsy one zone where mutation exists and another area where it doesn't. Liquid biopsies sort of hedge that off. If a patient has expression of, say, an EGFR mutation or T790 that's not found in the initial specimen, it's conceivable, and it has been documented, that those abnormalities can be detected at times in the blood where they were not detected in the tissue. And in that group, response rates seem to match those observed in individuals who have tissue-documented molecular abnormalities. So again, this is quite exciting. The presence of oncogenic drivers in the blood can be detected irrespective of the heterogeneity that will frequently exist in tissue.